My name is Hannah Wunsch, and today I'm going to talk about blood pressure targets and vasopressor therapy in critical care. Financial disclosures are that I do have current research funding from a number of organizations, none specifically for the work discussed here. So, thinking about traditional models for shock, and in particular for septic shock, we have a diagnosis of hypotension. Generally, there's fluid resuscitation, although that's been explored in detail recently. Often, if the blood pressure is still low, we then go ahead and start a vasopressor. And this has been our kind of traditional model for a very long time in terms of how to care for these patients. I want to recognize that in the future, when thinking about treatment for shock, it could look very different. And I think there is an interesting sort of proof of principle that was published now a number of years ago in Nature Medicine that used artificial intelligence to try to optimize treatment strategies for sepsis in intensive care, and specifically training it to understand when best to give fluids versus vasopressors. And this is the example of how the AI policy differed from the clinician policy. So what it's showing you is how frequently the recommendation or what happened was a vasopressor was increased or a dose was given versus intravenous fluids. And the main takeaway here is that once it was trained, the AI policy actually just looked different in terms of the clinician policy, in terms of potentially optimal choices. Now, that's all in the future, right? And there may be places that sooner rather than later have some element of this incorporated into their critical care. But for most of us, that's not going to happen anytime soon. And certainly for low and middle income countries, this is, something that we will not see anytime in the near future. And the reality is, even where I work in a top medical center in the middle of Toronto, I am still writing paper orders that say things like start norepinephrine drip at 5 micrograms per minute, titrate 0 to 40 to keep MAP greater than 65. Still really basic. And so I think we have to step back and recognize that if we're going to improve care for patients in shock and in septic shock in particular, we still need to focus on the basics and think about ways that we can tweak the basics to try to optimize care for our patients. So just a tiny bit of history about the drugs that we use to treat shock. Epinephrine and adrenaline were first extracted from the adrenal gland around 1895 to 1900. Phenylephrine was patented in 1927 and in medical use starting in 1938. Norepinephrine was identified in the 1940s. Dopamine was first synthesized in 1910 and identified as a neurotransmitter in 1958. And vasopressin was separated from oxytocin in 1927, but wasn't used clinically in septic shock until 1997. Now, I know there are other things like terlipressin and such, but I'm going to just kind of focus on these, which are really a lot of the main drugs that certainly are used in North America. So the reality is we've known about at least some of these basic drugs for many years, but I would argue we still know actually very little about how best to use these drugs. And there's a lot of potential questions we can ask. Does it matter which vasopressor you pick first? Does it matter when you start vasopressors? Does the blood pressure response matter? Does the blood pressure target matter? If you're going to add a second vasopressor, what should it be? Et cetera, et cetera, et cetera. You can see these are very basic questions, and we have some data to look at some of these questions, but not a lot. And I want to start out with this question, which is, the blood pressure response matter? Now, I got interested in this question looking at this study back from 2018, looking at hydrocortisone plus fludrocortisone for adults with septic shock. Now, a lot of studies about steroids and shock, but what caught my eye in this particular study was the fact that the patients who were receiving norepinephrine in both arms on admission to this study were receiving what I viewed as a very high dose of norepinephrine, about 76 micrograms per minute, 1.08 mics per kilo per minute, if you think in those terms, which to me is well above any normal dose that I tend to give in the ICU. And I looked at this and I thought, wow, if these patients are on that dose, they must all die, because any patient I have on that dose seems to die. But I was wrong. In this particular study, 46% of patients died, not insignificant, a huge number of deaths, but not the sort of 80, 90, 100% that I would have expected looking at that dose. And so that led to the question of, what does it mean to have a certain blood pressure or to be on a certain dose of vasopressors? And this question of, what is the response to vasopressors? And for instance, if someone's on 1 microgram per kilo per minute, what does that actually tell you? Well, we tried to look at this in terms of the question of whether or not we could explain the differences in mortality across different studies based on the dose that patients were on when they were enrolled on the study. And the question was, and this is work done at the time by a fellow, Bijan Teja, is there a correlation between the dose of vasopressors of the control group in RCTs and the ultimate reported outcomes for these patients? And we found it was sort of a scatter plot. There was not a strong correlation between the doses reported and the mortality. Well, there's a number of things that could be going on. One is confounding medications, things like sedatives that might be used, which require then a higher dose of vasopressors. There might be a lot of heart failure, septic cardiomyopathy that's not being described in some of these studies. There could be adrenal suppression. But one thing that jumped out at us was there was no real idea of what the blood pressure is with the dose reported. The two are kept separate in terms of the way we think about this. And so started to wonder if we could think about a P to F ratio for shock. And we know P to F ratio, right? And to go back and discover how that was generated was to go back to this paper from the 1980s. Turns out it was quite nice doing research in the 1980s. You didn't have to really do anything to propose something like a P to F ratio. You just put it in your paper and added some points. This is the lung injury score, and this is really when it was first introduced. Now, we all recognize its value because it allows us to talk not just about a PaO2, not just about an FiO2 in isolation, but to bring those things two together in a way that's clinically meaningful for us to understand how the two are related. So we wondered about a proof of concept for a P to F ratio for shock that used things like norepinephrine dose and the blood pressure. And this was led by Nick Bosch, who's at Boston University when he was a fellow. And we used two different data sets for this. And we looked at the first 1 to 6 hours after ICU admission and or the onset of use of vasopressors. And our outcome was hospital mortality. So to give you an example of what these data looked like, this showed you the minimum systolic blood pressure for patients and the associated hospital mortality there on the y-axis. And then the gray line bump there is just showing you the number of patients at each of those blood pressures. And you can see there's a correlation between minimum systolic blood pressure and increasing hospital mortality at the lower levels. It's linear. It doesn't actually provide you that much additional information. So then we looked at other measures, and the one that we ultimately settled on was this systolic blood pressure divided by norepinephrine equivalents as a ratio, because you can see that there's actually this really kind of useful point at which you can say, okay, below this point in terms of a ratio, you're starting to see really substantial increases in mortality. Now, what is that ratio there, that sort of turning point? Well, that's around 200. And that would be, as an example, a systolic blood pressure of 85 on norepinephrine of 30 mics per minute. So quite sick, quite high dose, but now starts to at least give us some sense of what it means to have this ratio that you can say, okay, yeah, that's someone who's sick. They're not just on norepinephrine of 30 mics per minute by the way, they're on 100 propofol. You can actually say, okay, this is the relationship between the norepinephrine and the blood pressure. So what about the blood pressure target? As I showed you at the start, I'm still writing keep MAP greater than 65. But obviously that's not good enough. And I think we're starting to tease that apart. Now, there are a number of studies that have tried to get at this question of whether higher versus lower blood pressure targets matter in patients with septic shock. And this is a paper back from 2014 that looked at this. Now, they got really nice separation between their groups in terms of their targets. However, I think this is important to recognize. Their actual targets were 80 to 85 and way down here at 65 to 70. And I think it's important to point out that human nature is to keep people at the upper level of whatever the target is or above that level, because you can see most people find it hard to tolerate, I think, looking at a blood pressure that truly has a map between 65 and 70. It feels low to us. And this is a universal problem. This is not just this study in particular. Now, in this particular study, the outcome was a no difference. I don't want to say negative, but no difference in the two arms, suggesting that at least with these targets and in this population, that it did not matter whether you kept them at a higher or lower blood pressure target. Now, others went on to use these data, and this is work led by Francois Lamontagne, who used the data from that study pooled with other data from Canada to come up with a hypothesis around whether or not age mattered. And just this is a slightly confusing graph. You've got age on the x-axis. You've got the odds ratio for mortality on the y-axis. And I put a reminder to myself here, an odds ratio greater than 1 favors the lower target. So as you go up in age, the likelihood, it seemed, that maybe the lower target was beneficial increased, which led to the 65 trial saying, okay, let's look only at the people over the age of 65. This came out more recently. And note the title, Effective Reduced Exposure to Vasopressors on 90-Day Mortality. It's not effect of targeting a certain blood pressure. Now, the two are intricately intertwined, but are not the identical concept. So this is looking at the MAP values on days 1 to 7 post-randomization. They did get some separation between the groups, not as big as maybe in the other group. And again, and this is the same problem, right? Here was their target, 60 to 65, and you can see the red bars is where everybody landed. So some people were in there, but not that many. And I honestly think the only way we'll ever get around this, if we actually want to target blood pressures that are that low, is to automate this and take it out of the hands of humans and ask a machine to keep somebody there, because we as humans really struggle with that. There was no difference in this study either between the groups. Some interesting kind of subgroup analyses in particular was whether or not chronic hypertensive patients actually benefited from permissive hypotension. Not intuitive. I'm not quite sure what to do with that, because it kind of goes against all of our theories, which is that if you're chronically hypertensive, you probably need to be at a higher blood pressure than someone else for future research. A related question that's raised by that subgroup analysis, if we target to a single blood pressure, such as MAP of 65, are we potentially harming some patients, right? And those subgroup analyses around hypertension, we're trying to get at that. But of course, being hypertensive could be treated hypertensive, untreated hypertensive, lots of questions there. And I think the question is really kind of the same as Carolyn Calfee has identified, looking at things like subphenotypes in ARDS, right? The same question, are there subgroup, subphenotypes of patients where a lower or higher blood pressure actually may make a difference? So we went on to ask the question, does baseline blood pressure impact delivery of vasopressors? And to do this, it's hard to find data where you actually have information on blood pressure before the ICU. We used data from 4 ICUs in Calgary, looking at patients with shock admitted to an ICU and vasopressors. And we determined their average baseline blood pressure from all prior, actually not just hospitalizations, but encounters with the healthcare system up to 3 years prior to the hospitalization. And our hypothesis was that patients with low baseline blood pressure would remain on vasopressors for longer. We didn't want to hypothesize around mortality. We did look at it, but we felt that really it's that question of, you've got that patient who just can't seem to come off vasopressors. And it's only when you sort of say, oh, to heck with it, let's just let their blood pressure run low, that you actually find out that baseline their blood pressure runs low. And how often is this happening, that we're sort of over-targeting blood pressure in people? So we divided people based on whether or not their baseline known blood pressure was low, normal, or high. And then we looked at the MAP they were run at while on vasopressors. And what we found was that for those with a low baseline blood pressure, they were being run at their own normal MAP most of the time. If their baseline blood pressure was normal, they were being run a little bit below 10 to 20 millimeters of mercury. And if they had a baseline high blood pressure, it was quite permissive in terms of that hypotension, or relative hypotension, I should say. So really shows that relative to where someone lives, we are taking care of patients very differently when we are saying, say, target MAP greater than 65 in everybody. Now, we did find that our primary outcome showed the time to discontinuation of vasopressors was longer in those in the low blood pressure group. That's the blue group there. And to kind of put it another way, which I think is a little bit easier to conceptualize, the time to 50% of the patients in that group being off of vasopressors was 1.88 days in the low blood pressure group, 1.3 days in the normal blood pressure group, and 1.2 days in the high blood pressure group, which really makes you think, do we have to rethink blood pressure targets in the ICU and also potentially in the operating room? Because clearly this suggests that we are maybe not targeting people similarly, or we're targeting people similarly as in a MAP greater than 65, but we are not targeting people similarly in terms of that relative decrease or increase from their baseline. So in conclusion, I think there are sophisticated techniques for titration of vasopressors in the future. We may see that in some high-tech ICUs in the near future. But I think for the rest of us, we're really looking at finding ways that we can improve the care for our patients using simpler techniques that can be sort of easily done at the bedside. Clinically, I would suggest considering baseline blood pressure when available. And I recognize this isn't always possible. We have patients who roll in who are unresponsive, unable to tell us anything about their history. But certainly for postoperative patients, certainly for many of our patients who are part of our health system long term, we do have this information if we go looking for it. And if you think about presentations about new patients, we talk about whether they're diabetic, we talk about whether they're hypertensive, but we don't actually identify where their blood pressure normally is. And also just to recognize that we have so many basic unanswered questions for future research related to how best to deliver vasopressors in situations of shock, in particular septic shock. So thank you very much for your time. And here's my email address for any questions.